Are you, my dear Boris? Ready? We go now? Okay, I think we can start. Hello everyone. My name is Philippe Landreau. I'm an orthopedic surgeon. I'm the X-Bone Chief Medical Officer, and you know, probably you are used with this educational platform now. I'm very happy to host you and to welcome you to our, I think, 11 live broadcasting from the X-Bone Forum. You know that the purpose of this forum is to develop the education, because we believe it's very important beside the patient care and the research. It's for not only for surgeons, it's for different all doctors, physiotherapists, nurses. And you must know that this is a live broadcast, but it's available forever on the X-Bone YouTube channel, and I encourage you to register. Then you can see this video whenever you want. I know that some people are working currently, and I know that usually they go to see the video later on the same link, so you can do that. Today I'm very happy because particularly happy because I'm welcoming a good friend, Dr. Boris Poberaj, who will talk about the long head of biceps. I think he's a guest speaker, one of the first guest speaker for the X-Bone Forum, and we are very proud and happy with that, and we will develop more in the future. Dr. Boris Poberaj is an orthopedic surgeon. He's performing shoulder and knee reconstruction surgery in Slovenia. He's from Slovenia. He's member of the surgery big tank group. And actually, I had the privilege and the chance to have Dr. Boris as a colleague in my team in Aspetar between 2015 and 2019. And I can tell you that he's a great man, a fantastic surgeon, and an educator and a friend, and someone that it's amazing and a pleasure to work with him. So he's reference in particularly in shoulder surgery in his region, and all over the world now, because he's involved in the ESCA board. He used to be the president of European Shoulder Associate at ESCA, and he's an active member of this organization. And he's known as well for having organizing the arthroscopy festival in Slovenia, where more than 20 live surgery are organized, and this is something quite amazing. And besides to be an excellent surgeon, an educator, and a man working with passion, he's a developer of a new surgical instrument, particularly for the biceps tenodesis. And it's one of the topics that he knows the best, and this is the reason I asked him to talk about this long head of a bicep, which is a controversial topic, and I'm sure we will learn a lot with Boris. Welcome, Boris. Hope you are doing well.
Thank you, Philippe. Thank you for this kind introduction and also invitation. I must say again that we spent 5 fantastic years in Aspetar, in Qatar, where we met. And I know that you with Bernard and Favas and Terry started the new project, which is already going on, and the X-Bone. I think you have a great future with this, and I wish you all the best with this. Today, I will, as you said, will present this talk on biceps. I will share.
I'll let you share your screen, Boris, and you have the microphone now.
Yes, just a moment. I will just share my screen. Just a moment. Yep. So let me see.
Just go down as we did.
I closed everything. So
because you closed your. Okay.
Now it's fine.
Better. Yeah, you're right.
Okay.
So launch the presentation and
Okay.
you're on. Perfect.
Okay.
Let's go.
Perfect. So my disclosures, I'm a developer of Cobra Guide. I will show you later on. Whenever we talk about the long head of the biceps, it's always association with a pain generator, a vestigial structure. And lately I find a nice description of the biceps as uninvited guest who never leaves the party. So why has biceps so bad reputation, and what is the problem with the biceps itself or around it, surrounding structures? I would like to explain and discuss about this, and also why overhead athletes are at high risk to injure long head of the biceps. If we take a closer look on the whole biceps brachii, we see that it has two heads, the short one medially and the long head here, laterally. And this long head of the biceps has very specific path through the crossing the glenohumeral joint. And that's why it's very hard to predict the real forces at the shoulder level, because the shoulder is the most mobile joint in our body. Definitely the first and the most important action of the biceps brachii distally is supination of the forearm. You see that the supinator muscle helps it, and once it's supinated completely, then it can help with flexion. And of course we have also two other muscles here, brachialis and brachioradialis, which helps in flexion. But we cannot do flexion without first supinate the forearm. If we take a closer look of distal insertion, which can help us to specify the function of the long and short head, we see that the footprint of the short head is a bit, the lever arm is a bit longer, so it's better in has better strength in flexion. But the longer head is its footprint is a bit more posterior, so it means that at the very end range of supination, it's more stronger, it's more efficient. What about proximally? Proximally, we traditionally are taught that long head of the biceps is a humeral head depressor. It has important role in shoulder stability, but these all studies are cadaveric ones. So what is actually real life? EMG studies show that there is actually no electrical or no significant biceps activity during shoulder motion. Also in vivo glenohumeral translation study, which was made after biceps subpectoral tenodesis, showed less than 1 millimeter difference of a translation of humeral head against the glenoid. But what we do know is we have reports from the States on from baseball games and especially pitchers. The pitchers lost performance after we do something with the biceps or they injure biceps. So to take a look what forces going through biceps, we see that there are a lot of shear forces, especially when we do, let's say, throwing the ball. We have tensile forces when the muscle contracts, and we have compressive forces when the arm is in complete abduction, external rotation, touching the acromion and surrounding structures. To think maybe that the biceps can be a good abductor of the shoulder, we face this problem because the path of the tendon itself is crossing the glenohumeral joint is going like in this fashion that when we pull the tendon, if the tendon wants to make abduction, it's not efficient because you see the forces are heading against the tubercle minus. So if we do anteflexion, these forces are even higher. So if we really want to do abduction with help of biceps, first we need to do external rotation, that we get the biceps tendon in line with the biceps muscle, and then it can become like a pulley type fashion abductor. To see the reason for that, we have to go back to history. And this is evolution, how we started, when we started to walk on two limbs. So we became bipeds. There were some modifications in the upper limb and thorax. You see that these mammals, first we had like very scapula was very laterally, and then by the time it moves to posterior. So this movement of scapula brings several adaptations. So first of all, the humor went to retrotorsion, and in the medial, the bicipital groove migrate more medially, as it's written here. So this all increases the medial dislocation forces. To make this easier to show you, I just put some pics on the with the help of the plastic 3D model. So this was before, when the scapula was still at the site. You see the line of the tendon actually is almost the same, or 10 degrees difference with the muscle belly. Then after, the thorax become flat, and especially if scapula came back posteriorly. And of course, if it stays like this, we will be like this, constant in lotus position, in Zen, very relaxed, but we cannot work like this. So Mother Nature turned this forearm, our forearm, to the midline that we can work with in front of us with the help of retrotorsion of the humerus. And now you see this angle is quite bigger. You see that the line when the tendon exits the labrum and then goes down to sulcus is more than 45 degrees. And this is the reason for these nasty forces which pushing the biceps towards the lesser tuberosity. Another specific anatomy in humans is that the sulcus is differently shaped because anterior wall is quite differently angled. So if we have like 15 degrees only angle, we can expect that this biceps can be more unstable. To see the biceps tunnel anatomically, we see it's formed by lesser tuberosity and greater tuberosity. And then we see that actually is covered, the biceps itself, with the synovial tissue. This is coracohumeral ligament. This is transverse ligament, which is extension of the subscap tendon and the supraspinatus tendon. There is one specific feature here, that the biceps runs inside the glenohumeral joint, but it's covered by the synovial tissue, which makes sort of a barrier. Another specific feature of this tunnel is the entry, which is made by two pulleys. We call this pulley system, made by two ligaments. I will show you now in a minute. So this is extension of the subscap. Then we have superior glenohumeral ligament in the front. Then we have biceps tendon. And then we have a coracohumeral ligament, which splits at the distal part to anterior and posterior band. So this pulley system actually guides the biceps tendon inside the groove. How we see this with arthroscopy, this is the left shoulder, this is posterior band of the coracohumeral ligament, this is the biceps tendon, and this is anterior coracohumeral ligament and superior glenohumeral ligament. This is anterior pulley. Now, another feature of biceps in the tunnel is the gliding, and there is some special geometry of the biceps. This interarticular segment is actually a bit flatter, and the diameter is larger than the distal one, which is also triangular in shape. What does it mean? So if we do abduction, it means that this bigger part of the tendon must squeeze inside the sulcus, and this we call elastic recoil. And now when we do abduction, we see that we have a gliding friction plus elastic recoil force. And when we go down back to the side, we have gliding friction as well, but minus elastic recoil, because the biceps get normal shape back. And for normal range of motion of glenohumeral joint, biceps needs to travel about 2 centimeters up and down in this sulcus. You can imagine if you do this repetitively, as in sportists, there are some possible speculations that this can cause also early degenerative changes. These changes are also connected to the blood supply of the tendon. So blood supply at the anchor of the tendon is quite weak. Why? Because we don't have any direct artery to the point, but rather the closest one is suprascapular artery. So all the blood supply comes from the network from the glenoid and the labrum. In the mid-substance, here somewhere, it's a well-known hypovascular zone where the tendon ruptures spontaneously at the most time. And then the distally, we have really rich blood supply from this anterior circumflex artery ascending branches. We know this from the surgery. If we do surgery open or arthroscopic, we have quite a lot of bleeding sometimes. The biceps anchor is quite elastic, as you can see. This labrum is more elastic than, let's say, in the South Pole. And biceps is connected to the glenoid directly to the tubercle and to the labrum. So, as I said before, this region is not really rich supplied with the blood. So the healing potential as we do this, like in slap repair, is lower. For this reason, there are some more revision cases. We know that this tendon gets extensive sensory and sympathetic network at this point, and this is maybe responsible also for a nociception, but also for the proprioception. Overall, the muscle, the biceps brachii gets motor innervation a bit lower down by a musculocutaneous nerve. We also have to know some variations which can predispose to pathology of the biceps. I just picked up the very frequent ones. You see that there is a sling here just before the entry to the groove. We can have complete attachment of the biceps throughout the intra-articular segment to the rotator cuff. We can have a double split origin of the biceps. Then we can have only adhesions at the very beginning. And of course, we can also have complete absence of the biceps tendon. So what can go wrong with these biceps? So we can distinguish two levels. One is the problem with the biceps itself, the tendon, and one with surrounding tissue. If we start distally with the tunnel, we can have, of course, some osteophytes, but most of the time some adhesions and scars, which can block the movement. So what we can do, what we can have with this is the retroflexion with internal rotation. You see how much the tendon goes out. This is approximately 2 centimeters. If we have adhesions, this is represented by this yellow elastic. We do the same motion, but we cannot because it's blocked. It doesn't go, and it's painful. So this is typically loss of internal rotation and anterior pain. If we have something wrong inside the interarticularly, so with this segment, like hourglass deformity, this is hypertrophy of the tendon. We have this problem. When we want to elevate the arm, you see that the tendon cannot slide along the sulcus, and it's impinging against the rotator cuff and the acromion, and this is quite painful condition. You can meet this very frequently also in some overhead sports. So another problem is the structures outside the tendon itself. We know that the tendon runs in near vicinity of rotator cuff, subscap, and supraspinatus. And if one of them is torn, especially subscap, the tendon will take shortcut and will just jump under the subscap. And this will even exaggerate the pain. Sometimes it goes also above the subscap, but very seldom. So how does it look? So this is typical the biceps, which came out from the sulcus, and it's actually cuts the subscap, and the subscap is detached. So when we pull out this tendon, we see that the whole tendon, the segment inside the sulcus is frayed, and this definitely cause some pain and problems. So we have to remove such tendon out of the joint, and then we can easily repair the subscap back. This is even worse case with complete medial dislocation. You see the biceps is completely medially dislocated, displaced, and the subscap is completely torn. So when we go in a suprapectoral space, we will see that the biceps, this is the pec major insertion tendon, you see, and the biceps is completely medially, so it's supposed to be here laterally, just next to the insertion of the pec major. But also we can have a problem with the supraspinatus and posterior instability. You see, it's already suffered, biceps suffered some degeneration and some partial tear, and so we need to bring back the supraspinatus. But always when we repair the cuff, we have to remove the biceps, because we can never reconstruct the pulley system back to normal. So we have to take out the biceps from the joint. And now the very common pathology in overhead athletes, but also other sports or some injuries. Superior labrum anterior to posterior. This is the name because there is the anchor of the biceps. Typical painful condition in overhead movements, but at rest not, because during the night usually they have no pain. But the sportists, they complain they have no power to throw. What is the mechanism? Mechanism is superior migration of humeral head, can be one time or can be repetitive trauma with the concomitant biceps tension. So I will show you now what is how it goes. Like one time or repetitive upper migration, superior migration of a humeral head with concomitant tension of the biceps. And you can get this peel off of the labrum and detachment of the labrum. And this looks like this. This is like when we fall, for example, in outstretched hand, sudden movement we are actually the biceps is under tension because you want to prevent the fall, and this happens, and this is one-time event, and we can get injured anchor of the biceps. So very frequent, we are talking about glenohumeral internal rotation deficit in overhead athletes. This is like a GERD. The mechanism actually is the same. Here, usually it doesn't come from, this is not one event, but repetitive movements like throwing action. Let me explain this. So when we do throwing action, this is abduction and external rotation. The center of rotation of the humerus is usually moving only about 2 millimeters up, so that there is no compression or action on the biceps from humeral head. If we have a GERD, so internal rotation deficit, this represents tight capsule, posterior capsule, and if we turn the same, if we do the same motion, like throwing motion, we see that the center of rotation moves back to the posterior glenoid as the and this posterior tight capsule represents this new center of rotation. And we see that the head is pushing the biceps up, and slowly it can produce slap lesion, and later on also the problem with the rotator cuff. So to explain this once again, this is early throwing phase in normal range of motion. So biceps is in its position, this center of rotation shifts minimally. If we have a tight posterior capsule, we see that the center of rotation moves back to posterior glenoid, and we had this problem. So the head is pushed up against the biceps, and slowly, day by day, training by training, and throwing by throwing, we can have this peel-off effect and displaced anchor of the biceps. Nowadays, before we have only 4 types. Nowadays we have many types which were popularized by Snyder. I will show you this first type, which is the degenerative changes happen in the anchor. Maybe this is even higher type, I don't know, grade. This is typical grade 2. You see completely detachment, the upper part, so biceps is unstable. You can have like a meniscus tear, like a bucket handle, which with normal biceps anchor, actually, more or less, grade 3, but grade 4, it's like a bucket handle which extends inside the tendon substance. So you have to do something, remove the biceps the best, and remove this bucket handle tear. So as I said, nowadays we have many different types of up to grade 10. So this is one of them, and this is the other one with labrum tear extends to the biceps. This is typical Bankart and slap tear. How to deal with diagnostics of biceps pathology? The clinical examination is definitely the one of the most important things, especially to distinguish between the proximal and distal biceps tear, because the distal biceps tear, usually we need to do surgery in about first 3 weeks latest. Whereas the proximal biceps tear, we can leave it even in a young population. We don't go for surgery. So taking good patient history is the half of the job, because the patient will say, I heard a pop sound proximally, distally, I have pain the elbow or shoulder. So you can imagine what is the mechanism, and to focus to the right treatment. The tests for biceps are usually very sensitive, but not really specific, because this is O'Brien test, and you see this is O'Brien test live. This is the biceps. In front is the anterior pulley, back is posterior pulley, in front is subscap and supraspinatus. Whenever something is wrong with all these structures, you have the same positive test. So you cannot say alone that positive test means that it's a positive test for biceps. Further down, we can do a lot of different investigation modality. But first of all, we have to take X-rays. Don't forget on X-rays. We have all these MRI, CTs, but X-rays are most important thing, not to miss something. And then we see that ultrasound is a good tool, but more or less the tendon is seen more when it comes outside. So it's very good because it can be dynamic testing, and not very good for the slap. The reverse is for CT, because plain CT will not show anything except some osteophytes in biceps tunnel. All the rest can be best seen by contrast mediums. So MRI arthrography is the best for slap, for intra-articular lesions for sure, and for pulley lesion. Also MRI, if it's good, like 3 Tesla, you can see a lot. If you are not sure, or or maybe you know the diagnosis already, you do arthroscopy. You see, this lady was a young lady, suffered from injury 8 months ago, small injury, and on MRI it was supposed to be a slap lesion. So you can really touch the anchor. You can pull the biceps inside for about 1.4 centimeters. But we found what? The upper subscap tear, which is so small that even in MRI you can hardly see. And the anterior pulley is also weak. So this was a bit of instability plus subscap here. So what we did was repair the subscap and biceps tenodesis. So the goals is always to reduce the pain and restore the function. The treatment options can be different, but you will see at the end there are almost only 2 options. So for the conservative treatment, if you have some tendinitis or something like synovitis around in the sulcus, you can start with really non-steroids, local steroid injection, or physiotherapy, unless there is no mechanical symptoms. It's the same as in the knee. If you have a bucket handle mechanical symptoms, it's hard that you will treat this only with the non-steroids and physiotherapy. The only anatomic reconstruction can be done is slap repair. All the rest is to remove the biceps out of the joint, so to do tenotomy or tenodesis. Lately, the tendon can be also used as autograft for rotator cuff and labrum augmentation. Now, if we take a close look for common pathologies like the biceps tendonitis, of course, we can start with steroids, non-steroids, but of course, tenotomy and tenodesis are always helpful final treatment. If we have unstable biceps, of course, the only two options, tenotomy or tenodesis. If we have slap lesion, of course, we have three options, slap repair, tenotomy, or tenodesis. We almost never repair labrum if we do tenotomy or tenodesis. And now the nightmare for overhead athletes, slap lesion. So when we discuss with these athletes who have slept here, we have to face these facts. If we repair this anchor, rehab will last 4 to 6 months. There is risk for re-injury. Return to play 65% in field players, in baseball pitchers less than 50. If we do tenodesis, the rehab is shorter. There is no risk for re-injury. Return to play 80%, but baseball pitchers even less. It's really unbelievable, but I think this is the only sport where they suffer so much from this biceps problem. Tenotomy is not recommended for young active athletes for sure. So what is actually tenotomy? Actually, we just reproduce spontaneous rupture, but we execute this at the the level of the biceps anchor and not somewhere in the middle. So it's 1 minute surgery. We just cut the tendon, which we can do several ways, and we can face then, especially in men, Popeye defect in about 45%. Pros for these techniques, definitely technical. It's easy, it's short operative time, relatively simple rehab, short recovery time. Cons, we definitely lose the length-tension relationship. Sometimes these cramps can be really annoying for the patients and also for yourself in the clinic. They say some loss of end supination torque, as I explained at the beginning of biomechanics. Why? And this Popeye deformity. When we do tenodesis, it means that we do tenotomy, but also we fix the tendon somewhere along its path. So we can fix it with our rotator cuff. We can fix it inside the bicipital groove or suprapectoral, which is my preferred one, or in subpectoral fixation. So I will start with the weakest one, soft tissue procedure. So we do some kind of sutures to pec major, or we do like a button loop and we just leave it to catch at the beginning of the sulcus. The bit stronger fixation is fixation on the top of the bone surface, usually on humerus, with help of anchors or endobuttons like unicortical fixation, as you see here. And this is intra also the strongest one. This is implantless technique. This is with the interference screw, and you can combine the suspension loop with the interference screw as in ACL. So I will shortly just briefly explain what is this Cobra guide and this technique I developed. So we drill first the tunnel for the biceps, and we put the guide, which called by Cobra guide, to the humerus, and we drill these lateral tunnels. Why I decided to do this? Because formally I went through both cortex, anterior and posterior, and here behind is axillary nerve just running around the humerus. So I was always in stress not to hit this nerve. So that's why I decided to pass these shuttle sutures out on the lateral side, where you can really level the tunnel and not to really hit the axillary nerve. So this will be the live surgery, just a few steps. I just I will not go through everything. So when we cut the biceps, this is the right shoulder. You have also outside picture. We pull out the biceps out of the skin, so on the front. You will see it here. And we just put on holding sutures. Nowadays I'm using labral tape, which is stronger. And we cut this proximal part, which is too much now, because we will fix this distally to keep the tension. Then we drill the tunnel for the biceps, and we put this guide, cobra guide inside. And these are two tunnels on the lateral side. You see now I will show you axillary nerve approximately is running here. So I just move my tunnels a little bit higher, so I will not hit the axillary nerve. Now I do the two skin incisions, which represents cobra bite, like a snake. This is where the name comes from. And then we start to drill these two 3 millimeter tunnels in order to get connection with this front tunnel. So they meet somewhere here inside the bone. And when this is done, then I insert the insert with the suture loops inside, and this needle will just catch these sutures. Everything comes in, runs inside the bone. So then we remove this guide completely with all these sleeves. And as you see, we pass these two shuttles through the bone. And now what is the last stage is just to pass the holding sutures we put before on the biceps through these loops, and simply by pulling these shuttle loops, we bring out on here on the lateral side these sutures from the biceps on the lateral side of the humerus. This is the second one. And then we just fix this. We pull the biceps inside, and we just do 6 half hitches. And we use bone bridge as a fixation point. So we don't use any implants, nothing. And the pull out is as strong as interference screw or even stronger. You see now, this is the loop. And this is the biceps firmly fixed inside the tunnel, and this we remove this marking stitch. So the pros for this technique for tenodesis in general is preservation of length-tangent relationship for sure, preserves supination strength and less chance of Popeye deformity. Cons definitely are longer surgical time, about 15 to 20 minutes, higher costs because of that, more demanding rehab, and of course, longer recovery. For the last thing about the biceps tendon to lately they use it, and also I use it sometimes for lateral revision, because as you know, the short head acts as a sling, conjoint tendon. Also the long head can act as a sling, support for the humeral head, not to dislocate. And this is one of the pics from the surgery. You bring the biceps through the subscap, fix it to the anterior glenoid, and over put the capsule. There's also a chance of in the very big rotator cuff tears that you use the biceps as a superior capsule reconstruction graft, which is still, I think, not a technique which will still need to be developed. So for the conclusion, what I showed you, we still don't know much about biceps function, that's for sure. We know from the evolution point of view that there is the biceps has really unfavorable biomechanical path. And we know that if surrounding structures like rotator cuff get injured, that there is always collateral damage to biceps, which even generates more pain because it dislocates out from the sulcus, and it's really it loses complete its function. So if I continue with this description of the biceps as uninvited guest who never leaves the party, but when it does spontaneous rupture, tenotomy or tenodesis, the host, actually the shoulder, is super happy, unless the host is the baseball pitcher. Thank you very much for your attention.
Thank you, Boris. Excellent. I think everyone knows everything about the biceps now, long kind of bicep, but I'm sure we have some question. And it was excellent. It was a great overview of this controversial um, topic. And my first question will be, do you think somewhere the biceps is like the appendix?
Yeah, it's actually like a vestigial structure. You're not aware that you have appendix, but when you have, and I'm sure you have a very short memory about this.
Yeah.
It's really a big problem. So we don't know. Maybe in a million years, if there will be no another hit of corona, maybe if human species survive, maybe biceps will completely disappear. We don't know. But so far, we really cannot say, we really confirm what is the real function. Although we know that, we see in the baseball pitchers, the performance after a slap repair or tenodesis, it's a tragedy actually. They cannot go back on the field.
Yeah.
But I think this is I heard at least, and also from my experience, I did tenodesis on handball players, let's say volleyball players, and they could all go back to play unless this was the only pathology in the shoulder. If we have a concomitant like the rotator cuff problem, different things, it's of course the return to play is lower for sure.
And I think I fully agree, and I have the same experience with the handball player, volleyball player, all these people. We don't have experience with the pitcher because it's really American, Australian, Japan, or this kind of country, and probably the cricket. We have some, but I don't know very well the pathology. I don't have a lot of experience with this comparison with our Indian colleague. As you talk about the slap, it's a good because you talk about the athlete. So you mentioned very well the indication about the slap repair, tenodesis, etc. But so if you have when a young athlete come to you, let's say a football player, because it's one of the most frequent, goalkeeper or not goalkeeper, but usually goalkeeper, because they are the most symptomatic for that. Usually this kind of lesion are not throwing shoulder, so it's more traumatic. If you have a young 25 goalkeeper with a traumatic slap 2, what is your first treatment? Do you think that you should restore the anatomy as he is not a throwing shoulder? You can, not only a throwing shoulder athlete, you want to restore the anatomy, or you want to be safe and say, okay, biceps tenodesis works and we'll do that?
For sure, I will. At the beginning, I was more in front of anatomic reconstruction, but later I saw, when I follow up these patients, they return back because the healing potential is really low there, and I think first of all, after surgery, they lose quite a lot of time, like half of a season maybe. It depends which time of the season you do surgery, but then after they can injure again the same thing. And I think if nowadays we know that they don't really lose performance to do tenodesis, I think I would go straight for tenodesis. I will not lose any time.
Yeah, because we changed a lot during this last year with the experience that we have.
Maybe the difference when I'm still going for a slap repair would be like even younger athlete, maybe the first time dislocator with the Bankart, which extends to slap. So I will reconstruct the labrum, and I will also continue with the slap repair because it's the same actually manner, the same thing. And I would give a chance to this player to go back to play and stay normal.
Yeah, because in this case, we don't know if it is a slap plus Bankart or a Bankart extended to the slap.
Exactly. Yeah. So in this case, I would go for repair, but this is the only case I would do. Otherwise, the ages higher than 25, 30, definitely I will never preserve the biceps. I mean, to fix it back as a slap repair.
I know that in the past, people were very shy to go for a biceps tenodesis, except, as you know, the French surgeon, because we are called in the world the the biceps killers, because we have this experience and the culture for 20 years, 25 years, because our mentor tried this bicep tenodesis and tenotomy with a very good result. And I'm happy that people are going in that direction now. But even though it's not a real satisfaction for a surgeon, because, you know, when you have a 25 years old boy or lady or girl to do biceps tenodesis for the rest of the life, it's always a sort of pain, you know, to do that, because we are not anatomic. But if we want to be pragmatic, realistic, it works very well.
Yes, that's why I agree completely.
If you talk about I don't know if we have some question, but I will continue, because I would like to have your opinion about different things. About the biceps instability, which is a quite interesting topic, because now actually it's the surgery that we are doing. Again, it's biceps tenodesis frequently, or a tenotomy if older patient. It's a sort of acceptation of our incapability to do something more anatomic. Do you think that in the future, for this kind of instability that you show, you know, with this lady, for example, who had a small lesion of the subscapularis plus some deficiency of the pulley, do you think that the future we can hope to restore, like in the hand surgery, small ligament more accurately?
I think it's nobody will try this. Maybe the industry would probably push this, because we will spend more suture anchors, ligaments, and at the end surgery will become very costly. But I think there at this point, at the level of the entry, the forces are so big that even if we reconstruct, if we put back the pulley or we put another ligament, I think this ligament will stretch somehow and it will be insufficient at the end. So I think it's no way even to think to probably technically we can do everything. We can make a pulley around with the ligament. We take I don't know, gracilis and put it around.
Oh, we tried in the past. We tried in the past.
Yeah. But I think everything failed. So nowadays they don't discuss about reconstruction of pulleys whatsoever, I think.
So it's a sort of depend as well on the conviction that you have with the real role of the biceps, and you mentioned that during your beginning of your presentation.
Exactly. I don't know if this maybe this proprioception plays some role in these cases when they cannot return to play. Maybe is this more than the performance itself, because the tendon itself is quite weak. You know, it's not a really strong one. And maybe this feedback of position of the shoulder, maybe this really is insufficient with this after tenodesis, and that's why they cannot return to play. Or this is probably many reasons for that. We don't know actually.
I have a question from Thierry Monfils. Interesting, because he said in case of long head of biceps tendon lesion, combined with GEARD that you mentioned. So for those who are not comfortable, it's a glenohumeral internal rotation deficit, you know, with this posterior capsule that you showed, you know. Thierry asked where to put the cursor between rehab and tenodesis as a treatment in an athlete.
So first of all, if we touch this specific topic, like internal rotation deficit, which we face many times in our clinics, sometimes the athletes comes early enough that they actually develop pain, They cannot throw also because they cannot really make a full external rotation due to deficit of due to internal rotation deficit. Actually, the contracture of the capsule, and they don't develop true slap lesion. So it's a bit beginning. So if they start to do slipper stretch to stretch this posterior capsule and brings this center of rotation back to normal, maybe they can avoid any kind of surgery. So at the beginning, very beginning, I never go for surgery or tenodesis, but always try with physiotherapy, because even if you do surgery, you need to stretch your posterior capsule. So first, to bring this capsule back to normal, and then they try to start to throw. If they still have pain and there's on MRI arthrography still there's a gap which shows that there's a slap definitely, this slap doesn't heal. This will not heal, never. So slap never heals. This is what we have to know. So for this reason, if this is the player, we don't want to lose another season. I just decide to do tenodesis. So of course, if I know if I have a pitcher, I will go for slap because he has better chance to go back to play. But otherwise, I will go for tenodesis.
I think it's an important message is to do this slipper stretch first and not to go to a biceps tenodesis the right way and to have the problem of knowing that you can have some degree of capsulitis, postoperative capsulitis. So it's very important.
Yeah.
What about the this hourglass biceps that our friend Pascal Boileau developed years ago, and now he's not anymore talking about that. By the way, I didn't find a lot. What is your experience?
I found I had a few patients, and
obvious.
It's so obvious. The last lady was she was squash player or something, or badminton, something like that. So sudden forceful movements, and it was so typical that it's like you see the pathology through shoulder, because when she wanted to elevate both shoulders, the one she couldn't. I mean, like was feeling like it's blocked. Like they say that really it's my shoulder is blocked. I cannot elevate and I have pain. So this is the typical clinical sign, and I don't see this in of course in all three cases were young adults. I mean,
don't you think that it was over? The frequency was overestimated because he reported
for sure
percentage which was huge, and
no.
We look at cautiously because it's something that we want to we test always. That as you saw in the you show us in the presentation, but it's not so frequent. Huh?
No, it's not frequent, and I think it's more they confused with the hypertrophy when you have also rotator cuff tear, and then you have really face this hypertrophy of the biceps tendon.
Your technique is very nice, elegant. I knew already. Thanks. Do you consider that it's because we had already a discussion together? That I think that a too rigid fixation for a biceps tenodesis, for me, it's a danger because you kind of over tensioning. So to summarize, I always say that tenotomy works well, but we have some cramps sometime on the Popeye sign. So this is the reason why I'm doing, when I do a tenodesis, I use an anchor because I want to do what I call a tenotomy plus. So it means advantage of the tenotomy, but you try to avoid the disadvantage. And I don't want to go for the big screw because first of all, there is still a risk of fracture of the humerus.
Yeah.
Not huge, but and it's quite rigid. How do you qualify your fixation in this range of?
Yes, exactly. This is advantage because it's somehow there is some elasticity. So there's a pull of the tendon, but when there is more pull, more tension, the sutures come in actions more. So the main thing is that you really do a good passage of the sutures. Nowadays I'm using a labral tape because it's a bit stronger. It's not so aggressive. And so the second thing is about what is the tension. when you do tenodesis.
Yeah.
So basically, if you don't do enough tension, you will always have not enough tension, and you will have a problem like a Popeye or something, or even cramps. So basically, lately they speak that it's better to overtense, because muscle in the long term will adapt to this new length and tension. And finally, you will have a functional muscle. So basically, nowadays they are saying that it's better to be, the best, of course, is to be the tension just enough. But sometimes you cannot do this. I'm using this marking stitch to know exactly where the tendon was before when I'm drilling the tunnel. But basically, it's better to be a little bit over tension than less tension.
And Thierry asked the question, that same topic. Do you think your new technique could be interesting for pitcher?
For pitchers? I don't think so, because it's not a problem about the tenodesis itself. I think it's a problem of loss of proprioception, and I don't know what else. It's not about the techniques itself. So we will see what will happen with this. Maybe.
And I'm very happy because we have a question from Ali Magdes with
from Kuwait.
Kuwaiti surgeon, for good friend and someone who knows very well the shoulder. So his question is, hello Ali, nice.
Ali.
Je peux parler en français. I speak currently French, so I can say bonjour Ali. So how do you best detect and diagnose a problem of the intra-articular portion of the biceps tendon? Which imaging do you use to look at the intra-articular part?
Yeah, for sure, the best would be MRI arthrography.
Yeah.
Because if you have, let's say, for instance, split of the biceps, which is really seldom, but sometimes you can't see otherwise, then you use contrast, because contrast will go inside. And also hypertrophy or partial tears, you will see the most with the best with the MRI arthrography, for sure.
Better than arthro CT scan?
CT scan, you can see as well, but as you know, CT scan is quite a lot of irradiation. So I did it before a lot, but now with new machines, MRI, I think you see much better.
Yeah,
even.
After MRI is fantastic when it's correctly done. It's great. You see the structure of those tissue. You see the joint.
Exactly.
You delineate all the. So it's fantastic. I hope this question, this answer, satisfied our friend Ali, but he would be happy to have his opinion. Because he used some time in France. So, in France, we like to inject contrast in the joint. So I'm sure it's not a coincidence. Maybe one more question quickly. Tell us a little bit more before we close this new technique of using the biceps as a sort of Latarjet, as it has been proposed.
So actually, when you face the patient after Latarjet failure, I mean that this patient or athlete is having another dislocation. So usually you face with insufficient capsule, because you somehow not remove it, but depends which technique you used. If you have still a bone block there, maybe the screws are a bit bended, but towards the medial, so it's not facing against the humeral head. There is another chance not to remove everything, because it takes time, because if you have bended screws, you have to do open surgery to remove everything, and maybe to use graft. So it's easier that you take this long hair of the biceps. You can do this all arthroscopically, and you make a passage through the subscap just lateral to conjoint tendon. You have to know there is a big mess around the conjoint tendon and subscap after Latarjet. It's a lot of adhesions and everything. And axillary nerve is just next to it. So you go a little bit more lateral. You put this biceps in. You prepare the glenoid. You fix the labrum, and you just take the rest of the capsule you have to bring everything back, to actually to reconstruct the anterior wall and all the ligaments you still have there. And it's not, I mean, it's really, I would say, planning, it's individual planning for each patient, because you cannot treat every patient with this technique. But even without letter J, you can do this. Sometimes if you have loose capsule, you can use this biceps tendon as a
plastic.
Yes, like a sling, like don't use the whole coracoid, but just the long head of the biceps. It's also an option.
And one more question, technical question from Ali. In your tenodesis technique, do you open the transverse ligament until the superior part of the pectoris major?
This is a very good question, because I know what is the reason for this question.
Yeah.
Because we still face sometimes pain after tenodesis. And what they say, what they propose is that you have to open the groove, the tunnel, so to open the transverse ligament and to clean everything, so the bone bed and all around with shaver and vapor, because there is some nociception receptors and maybe some inflammatory cells or whatever, which can cause this prolonged pain. I don't do regularly, but if I see very, very inflamed tendon, I go up and I go with the vapor and I just clean everything and I try to kill all these inflammatory cells.
Okay, Boris, so it's time because we have to finish. We could discuss hours. Thank you again for this great talk, great discussion, and a pleasure to see you again. So for people just arriving in this broadcasting that can just re-look, or if you want to look again, it's available on the DXBone YouTube channel permanently, like other presentation, because we have now 11 broadcasts. And I'm sure we'll invite you again in the future to talk about shoulder, because it's a pleasure, and you are a great education man. Thank you for that. Enjoy your family and your country, Slovenia. I hope everything is going well there, and we hope to see you soon. So thanks everyone. Yeah, thank you, Boris.
Thank you, Philippe.
We will do summer break, because we need to do a summer break somewhere. So we stop now to go back early beginning of September. So we plan to start the 8th of September. So you will not have to log in and to look at YouTube for broadcasting during your vacation close to the swimming pool, because it will the next one will be the 8th of September, and we'll talk about pain management. Very interesting lecture you will see done by our colleague Dr. Tariq Nassar, specialist of this pain management, and I'm sure we will learn again. Thank you, everyone. Stay safe and take care.
Thank you.
Thank you, Boris, again.